Hello there, everyone. Thank you for joining me today, and big thank you to the IO as well for inviting me to do this. Some of you may have seen this off the back of an article I just wrote for the Osteopathy today. So that's just come out this week, and it's an area that I've been interested in for a little while, and so I'm going to share a few of the thoughts and sort of understandings that have come to me over the last few years as I've researched it. Now, in terms of the sort of etiquette for today, if you like, it's probably easiest for you to send questions after the event. So what I'm planning on doing is the main body of the webinar now for about an hour, maybe just give or take 10 minutes, and then we'll do questions afterwards. Now, I can access my questions, but it obviously just distracts from the presentation itself. I'm just going to have a quick check and see what I can see here. Oh, that didn't help. We just got out of the presentation. There we go. Okay, good. So yeah, I think it's going to be a little challenging for me to take questions whilst I'm presenting. So obviously, if I hear a bunch of questions coming in, then I know something's happened. Perhaps the internet's shaky or something like that, or the slide isn't showing properly. So I will stop and have a look if I'm hearing a bunch of messages coming in at once. But otherwise, we'll just get started. And like I said, we'll do questions at the end. So off we go. So this now this presentation, I've dragged quite a few slides from a recent presentation I did back in March, where I was out in Australia and New Zealand, and some of you, I expect quite a few of you may have seen me advertising this. It was, I called it 2020 vision, so you see that down in the bottom corner there. But what I was using to advertise, I'm going to cover some of those key slides in the presentation today. I think I'm getting a few questions coming in, which is slightly concerning me. Let me just see if I can get to my questions. Yeah, maybe they're not questions. Maybe it's just people joining. Okay, well, we'll continue with the presentation. So the interesting thing that we have at the moment is that we have more pain neuroscience than ever before. We have more orthopedic surgeons than ever before, better imaging techniques than ever before. We have better drugs than ever before. We have more manual therapists than ever before, but we have more persistent pain than ever before. And so the question there was, are we barking up the wrong tree? And I think, of course, what my suggestion is that yes, we are barking up the wrong tree. It's not to say that any of those things are bad or wrong, or that they need a dramatic change. I just think we might need to shift the way we're thinking about things, and this is where central sensitization comes in. So we're going to obviously address that as we go through. So when I put that out, I did get questioned by one or two people to say, well, hang on, I didn't think the persistent pain was on the increase. I thought it was on the decrease. So I thought I'd better do a bit of a fact check. And so I did. I had a quick look at a few papers. And so this one is obviously a fairly old paper, but it's from O'Sullivan, who, as many of you will know, is one of the leading thinkers in the pain neuroscience fields. And he says that USA data supports that in spite of an enormous increase in the health resources spent on low back pain disorders, the disability relating to them continues to increase. So that was 2011, so that's a little while back. But then in 2015, said something fairly similar. In spite of enormous and increasing costs, current approaches to management are fueling rather than reducing the burden of the problem. So that's obviously a little bit concerning. Then I thought, well, I'd try and find something more recent than that. And I found a paper that came out in December 2019. And it's about the 18-year trends in the prevalence of and healthcare use for non-cancer pain in the United States. So in other words, really what we're talking about primarily is musculoskeletal pain here. Okay. And so what you see in the graph over here is that essentially the trends are all upwards. Okay. There's perhaps a very slight downturn here from 8.5 to 8.1, but really the trends are not looking great for persistent pain. And of course, if you think of it in terms of what we just looked at, that we've got all of this amazing knowledge and technology and techniques and insights, we would expect that at least to be, reducing, if not gone. But but we're not close to that. And so what we know is that chronic pain affects more Americans than diabetes, heart disease, and cancer combined. And so, you know, when you think of the sheer sort of size of those problems, it shows you how big chronic pain is in relation. And chronic pain isn't just an American epidemic. Over 1.5 billion people worldwide suffer from chronic pain. So that's about 20% of the world's population are suffering from chronic pain. So as osteopaths, what that really says to me is that, you know, both we've got a huge opportunity to help people, which is the primary thing. And of course, from a business perspective, there's plenty of people that need our help. Okay, so are we barking up the wrong tree? That may be part of the reason as to why this seems to be getting worse rather than better. So, you know, some of the zeitgeist and the sort of the way things have been going over the last few years is to move away from a structural model, move away from things like core stability, move away from things like posture, which I think for osteopaths and manual therapists has been a real key part of how we've worked with people. And you know, I'm quite interested in this because I think, like, whenever there's a change in the wind, as it were, quite often there's a swing of the pendulum. It goes a little too far in one direction, and I think it's about to start to swing back. And I'm going to explain why that is through the webinar. So these are just a few examples of some of the sort of papers out there that are challenging the kind of prevailing paradigm. Obviously, A.L. Lederman is one of the key people that does that. There's a guy called Adam Meekins. There's a few other papers we're going to look at as we work through the presentation. Ben Cormack is another guy who's very sort of anti the idea of postural effects on pain. So anyway, we're gonna touch on that and link it in with the whole central sensitization side of things. So part of my most recent interest in this comes since writing these two papers, which I put out in the Journal of Bodywork. So I have to write an editorial a couple of times a year for the Journal of Bodywork and Movement Therapies for their rehabilitation section. And this set of papers I actually co-authored with Paul Check, who some of you will know I've done a lot of training with, and I teach for the Check Institute. Interestingly enough, Paul actually did a lot of work under the auspices of well, he was a massage therapist and an athletic trainer in the US Army, but he was working under the wing of an osteopath. So you can see in his thinking there's a lot of osteopathic philosophy. Anyway, so Paul and I wrote this paper, and essentially what we were calling for with the paper was that really, when you look at a lot of the research that's out there at the moment, most of sounds obvious, but most of the pain neuroscience is focused on pain. And so what we were suggesting is that really we need to focus beyond the pain. We need to look more towards function, towards performance, because if you focus on pain, then first of all, it's a negative focal point. But second of all, it doesn't necessarily correlate with dysfunction. So in other words, you can still have pain and function quite well, but also you can be out of pain and not be functioning well. So pain is not really a good focus if we're looking at people realizing their potential, which is what I've always been interested in as an osteopath. So the other element here is looking at awareness of how the unconscious behavioral programming accounts for the majority of lifestyle habits and perceptions and may facilitate more effective outcomes when addressed. So now, we're not going to talk so much about unconscious behavioral programming here, but what we are going to talk about is central sensitization and what drives central sensitization, and most of that is unconscious habits. And indeed, a lot of the neurology that's occurring and the neurophysiology is unconscious as well. So, you know, we're not thinking about our abdomen bloating when we've just eaten some gluten. It's happening unconsciously because our nervous system knows how to respond to that irritant we've just eaten, for example. Okay, so a lot of this is unconscious. So when you look into the research on pain neuroscience, as I did for those two papers, then what you find is that some of the key drivers of persistent musculoskeletal pain are beliefs around the pain, and especially fear avoidance behaviors. life stresses, so the being exposed to life stresses or significant emotions, especially traumas, and in fact, especially traumas in childhood, can really predispose people to central sensitization. Anxiety and depression are other examples of emotions that can particularly drive central sensitization. Then gender also plays a role, so females are more affected than males, and there's various theories as to why that may be, but none are conclusive as of yet. Then we've got age, so the older you are, the more likely you are to get central sensitization, and that's really down to exposure, because as we're going to talk about, central sensitization is essentially the notion that well, it's the notion of facilitation. So the law of facilitation states something along the lines of each time a impulse traverses a given set of neurons to the exclusion of others, resistance to that impulse will be smaller on each future occasion, something like that. So the idea being that, of course, the more you feel pain, the more exposed to pain, the more likely you are to develop sensitization. We also know that disrupted sleep patterns are a driver of persistent pain as well, and central sensitization. So that's something to look out for, obviously, in your patient histories. Then finally, we've got propensity to central sensitization, and that is something that, of course, again, is a driver in persistent musculoskeletal pain, and this is the topic that we're going to focus on today. So what is central sensitization? Well, central sensitization was first proposed by Woolf in 1983, so that's quite a while back, and it's been defined as persistent nociceptive stimulus creating excitation at the cord, lowering pain thresholds, and increasing pain perception. Now, it turns out that sensitization doesn't just occur at the cord, it actually occurs in the brain stem itself and in the brain, but that was the original definition, and there have been various iterations of that since. In fact, in the article that I wrote for the Osteopathy Today, I wrote that about a year ago, and so I was talking a lot about central sensitivity, which, as far as I was aware at the time, was a better, more accurate sensitization. And there's one author in particular called Eunice who has done a lot of writing on that. But I'm currently writing a paper with a guy called Joe Nidges, and now I'm not sure if I pronounced that right. That's probably a very Anglo-centric way to say his name, Nijs. But he is really one of the world leaders on central sensitization, central sensitivity, and so on. And he says that really the idea of central sensitivity as a term is falling out of favor, and everyone's tending to favor the concept or the term of central sensitization. So we'll stick with central sensitization for today. So now the image that you see here, we're going to dive into that a little bit later and go through it, but it's just giving a little bit of an example of how you get sensitization in the dorsal horn, and you know it's impacted by all kinds of things, from the viscera to the mind above, to injuries below, to the biochemistry, etc. So we're going to look at that a bit later. So let's look a little bit at some of this information around posture, and you know, as osteopaths, I think we quite specialized in understanding posture and watching how people's posture changes as they move, whether it moves in a symmetrical and what seems to be a functional and efficient way. So, you know, when you jump on any of the pain neuroscience forums, then what you tend to find is that posture is considered to be over-focused upon, and I think that's probably a fair analysis. Because there's a lot more to pain conditions than posture alone. However, you also get people that have taken it so far as to say posture has got nothing to do with pain, and they cite certain studies, and this is one of the studies that they cite. You know, this is one of the most commonly cited studies. I've asked on several forums several times, and this one comes up quite regularly. And essentially, it was a study by Christensen and Harvigsson, and they're looking at spinal curves and health. It's a systematic review of the epidemiological literature dealing with associations between sagittal spinal curves and health. And essentially, if you read the abstracts, then it says there's no association between sagittal spinal curves and health, including spinal pain. So this seems to be why people cite it as being, you know, posture being irrelevant to pain. But if you actually read the paper and you actually dig into the paper, then there's an issue. And so I use this as a kind of adverts for these seminars I was doing down in the South Pacific. And I was saying, you know, the data are in, and then in the comment below I said, but the problem is the data are corrupt. And so we're going to have a little look at that. So this is the actual study. So of course you'll all be aware meta-analysis is where you get all of the studies on sagittal spinal curves and pain. I think, if I recall, it was several thousand that they managed to get together, and they whittled them down to the highest quality. I think it was 52 or 54. I can't remember. It's 52 or 54, but it was 50 something. And here they are all listed. I'm not going to count them up, but these are all the papers. Okay, and this is showing whether there's a correlation between posture and pain. Okay, so all the ones that are in green are saying yes, there's a positive correlation. The red ones are saying there's no correlation, of course, and the orange ones are saying it's unclear. So when you look overall, then there's more green on the chart than there is red, and there's a little bit of orange as well. And so what you see is that there's 28 of the studies said that there's a positive correlation, 21 said there wasn't, and 5 were unclear. So you can see that there is some seeming correlation, but it's clearly not completely distinct. Okay. Then you have to say, well, were they looking at the direction that the spine moved in? So in other words, if you've got someone who's got, let's say, you know, facet inflammation, irritation, degeneration, well, they're going to be aggravated more by extension because it loads the facet joints more. If you've got someone with disc bulges, posterior disc bulges that are symptomatic, generally speaking, flexion is going to aggravate those. Now, there are always exceptions to these rules, but those are the trends. That's why after millions and millions of hours of clinical experience, the orthopedic techs and the orthopedic surgeons and the orthopedic specialists all agree that flexion, and all osteopaths, I think, would agree that flexion typically aggravates posterior disc bulge, extension typically aggravates, let's say, you know, a facet irritation or a spondylolisthesis or a spinal stenosis. But the problem is these studies were not looking at individual spinal pathologies. They were looking at low back pain almost entirely. So in other words, you know, if you get a group of 100 people with low back pain and say, well, do they all have flat backs? What you find is no. Some of them have flat backs, some of them have neutral backs, and some of them have, you know, hyperextended or hyperlordotic backs. So what you end up with is, you know, essentially data pointing off to the right, data pointing off to the left, and you end up coming back to the middle. And the assumption is that it's just like a straight line, but it really isn't. It's like, you know, the way that the data has been interpreted in this paper is a little bit like saying, well, the spine is perfectly straight because the head's above the pelvis. And it's like, well, no, it's not. It's got a lordosis, it's got a kyphosis, it's got another lordosis. Just because you end up in a straight line at the end of it, straight above the pelvis, doesn't mean that the spine is straight. But that's the interpretation that's been used here. Now, when you look at the 2 studies, there were just 2 out of these 52 studies that were specifically looking at disc injury, okay? And what you found in both of those studies, these are highlighted in yellow, that the group had consistently a decreased lordosis. In other words, they had a flattened lumbar spine, and that's exactly what you'd expect to find in a disc injured population, okay? So, because it loads the discs more. Now, not to try and labor the point too much, but I think these are some of the issues. At the moment, we've gone too far in the direction of suggesting that posture has no relevance. So in other words, we're using fairly linear or causal disease epidemiology to ask questions such as, does poor posture equal pain? And this is an image, by the way, from the Ghost in the Machine paper, which you can all access because it's in the Journal of Bodywork and Movement Therapy, so you should have access to that. And that also will give you access to a lot of the references that I'm putting up here. So, you know, if we ask a linear question, does poor posture equal pain? Well, the answer is no, because not only are there multiple different ways you could have poor posture, but there's multiple other factors that contribute to pain. So if we were to take more of a complexity-based disease epidemiology approach, then a better question would be, could posture be part of the etiological matrix of a musculoskeletal pain patient? So you could have, for example, poor posture here. So this is part of the matrix. You could have high stress there. You could have high caffeine consumption, pro-inflammatory diets, poor sleep patterns, poor blood sugar control, DIMS, which is a pain neuroscience term for danger in me, so a perception of this is dangerous, this pain is threatening. Then you could have tissue stress, impaired tissue healing, and those things combined across time will result in pain. The interesting thing is that if you add to that things like the hormonal status, the belief patterns, the emotions, the biochemical status, the trauma, whether it be physical or emotional trauma, the autonomic status and the visceral status, all of those things contribute to sensitizing the cord and sensitizing the central nervous system, so you end up with lower pain thresholds, and across time, which is in blue, the end result is pain. So therefore, does working on the posture help? Yeah, almost certainly it does. Is it gonna get rid of everyone's pain? No, almost certainly not. You need to work on lots of different factors, particularly with these persistent pain cases. Okay, so now to another one, the myth of core stability, or core stability myth, or myth understanding. So now, before we talk about the transverse abdominis, which I know a lot of people associate with core stability, of course, the multifidus is another element of core stability. And so this is an image of the multifidus just in here. Okay, so this is the multifidus there and there on both sides. Okay, we've got a couple more images of multifidus actually, but this is showing mild multifidus atrophy. Because what we know about low back pain is that the moment that low back pain comes on, the multifidus appears to atrophy. However, we know that also the multifidus cannot atrophy that quick. It takes weeks for atrophy to actually occur. So, but within 24 hours, we can see on average that the symptomatic side is 69% the cross-sectional area of the asymptomatic side. So if you imagine you've got right-sided facet pain or right-sided disc bulge, well, then if you were to do an MRI or an ultrasound 24 hours later after onset, what you find is that this multifidus is seemingly about 69% the size of this one. Okay, now months after this, if it's not rehabilitated optimally, is that the multifidus starts to atrophy and you get fatty infiltration. So that's what you see here. You see fatty infiltration occurring there. That's less than 10% of the cross-sectional area, and therefore it's mild multifidus atrophy. Here, you can see this is more than 10% of the cross-sectional area, but it's less than 50%. So that's called moderate multifidus atrophy. Then you've got this one, and this is now getting beyond 50% of the muscle, so that is known as severe multifidus atrophy. So this is people with persistent ongoing pain, okay, and almost certainly they're going to have some central sensitization associated with that. Okay, so this will sort of become clear why this is relevant as we work through. So what you see here is the longus coli. Now, I couldn't find specifically a cross-sectional area slide like this at the multifidus, but essentially, when you look in Gray's Anatomy myology section, what you find is exactly the same information, that all muscles, the deeper you go in a muscle tissue, the more tonic fibers you have. The more superficial you go in a muscle tissue, the more phasic fibers you have. So you see the white fibers here are phasic, the black fibers are tonic, and this is deep in the muscle, that's superficial in the muscle. So the same applies to the multifidus. So if we look at the characteristics of phasic and tonic muscles briefly, then, or I should say not muscles, but muscle fibers. Now, this is perhaps an important point to just bring up. When Yanda first brought out his concepts around muscle imbalance, which again, some people seem to think have been refuted, but I can't find any good literature that actually does that. There's a couple of blog posts which have some suspect information about how the muscle imbalance syndromes don't work, but I think they may be missing the point a little bit. The muscle physiology is, when you look at it, the muscles that are defined as tonic are not tonic in their entirety. No muscle is entirely tonic. Every muscle has a combination, as we just saw on the previous slide, of phasic and tonic fibers. So the deeper the muscle is, the more tonic fibers or slow twitch fibers it has, and the more superficial the muscle is, the more phasic fibers it has. So deep muscles like the deep multifidus or the transverse abdominis, they are classified as tonic, even though they still have some phasic fibers. And so their characteristics are that they are slow twitch. In other words, they are postural. They fatigue late, therefore. They have a low threshold to stimulus. So that means that they activate really quickly. But the downside to that is that, and then, you know, when I say, I won't go, before I get into the downside, they activate really quickly, and that's what's known as the feed-forward mechanism. So essentially, these deep intrinsic muscles act on intention. So the moment you're intending to move, they will engage before the outer muscles start to move you. Okay, about 30 to 90 milliseconds, depending on where you measure the contraction. So, so they have a postural dominance. Oh, now before I move on to that, so the low threshold is perfect for this feed-forward activation mechanism, but what it's not good for is when there's pain present, because when pain is present, the low threshold means that the pain inhibits these motor neurons first and foremost, and therefore you don't get firing, or you get late firing of these tonic muscles or tonic muscle fibers. So they have a postural dominance. They tend to be deep, therefore they're called the inner unit, often known as local stability muscles. They're normally monoarticular, but sometimes they'll go 2 or 3 segments like the multifidus does. And Yanda said that they tend to shorten and tighten, and I would say that this is perhaps the least accurate of these characteristics, because it's variable. They might have a trend towards shortening and tightening. For example, the pec minor is tonic, and it tends to shorten and tighten. The pec major is more phasic, doesn't tend to tighten nearly as much. But so the last characteristic is that they have a high spindle cell density, which means they're highly proprioceptive. So they have a very important role in proprioception. And so when people are in pain, these fibers get shut down, they get inhibited. Because they're shut down, the spindle cell information is not coming back from them, because essentially they're not engaged. And what that means is that you lose proprioception around those segments. And this is something that's well documented in the pain literature, is loss of proprioception when pain is present. Okay, so then of course the phasic side, well, it's just the opposite of the tonic. So it's fast, it fatigues early, has a high threshold to stimulus, so it's more difficult to activate, but also it's less permeable to pain, if you like. It has a mobilizer dominance, more superficial, outer unit, global stability, often bi or polyarticular. Again, this characteristic, Yanda, you know, again, I wouldn't necessarily agree with that in a high percentage of cases. The hamstrings is a good example of a muscle that is classified as phasic, but actually often shortens and tightens. So, you know, that one take with a pinch of salt to some degree. And then the low spindle cell density means they're not very proprioceptive. They're a little bit clumsy. Okay. And so how I define these, I often explain that, you know, tonic muscles are like refined ballet dancers. They're super exquisitely coordinated. And phasic fibers are like your big burly rugby forwards that just run through stuff, right? They blam through things. They're not going to be the best dancers on the dance floor. If you've ever seen rugby players dancing, it's generally more humorous than it is impressive. Anyway, so there's the Punjabi's model there, and really just sort of relating back to the idea that when you've got pain inhibits the tonic component of the active system, but the phasic component of the active system is left to work properly. And often that pain is being generated from the passive subsystem, things like discs and joints and so on. So we'll come back to that later. So here's the multifidus again. So you can see this is the side where there's seemingly some atrophy or some inhibition. But if we look at where that is relative to the center of axis of rotation of the spine, then what you see is the deep fibers of multifidus are obviously close to the axis of rotation, and that means that they have a more of a compressive effect. And the superficial fibers are, of course, have greater leverage, and therefore they have more of a phasic effect. And so what we see is that oh, and yes, so this is the erectors. So this is just showing you the lumbar erectors here. So the leverage is even greater in the lumbar erectors proper. So what you see is that you've got a high spindle cell density deep in the multifidus. You've got a high number of tonic fibers deep in the multifidus. And as you move out, you get more phasic fibers. And as you move into the erector spinalis, you'll get more phasic fibers still. Okay. But what this means is that when there's pain, then pain inhibits the tonic fibers. And so if you recall, where was the inhibition and the atrophy and the fatty infiltration occurring in those previous pictures with the multifidus? It wasn't out here, it was deep in here. So it was this deep intrinsic fibers, the tonic fibers of multifidus that get inhibited by the pain, and then that creates fatty infiltration across time. Okay, so so it's not just about the fibers though, it's about the motor neurons. And so this is important to understand as well, because I've come into one or two conversations with people who are of the view that you know, core stability or motor control is largely irrelevant when it comes to pain. But you know, they were making the argument that something like the multifidus is about a 60-40 split of tonic to phasic, and that's true. That's what the research seems to show. So the multifidus, yeah, 60% tonic, 40% phasic. So that would categorize it as a more tonic muscle, but it's a tonic dominance, not entirely tonic, and that's important to understand. However, when you look at the motor neurons, what's really useful to contextualize this is that the motor neurons, that before we do that, the example that I've got here is, if you look at, I was trying to find the number of fibers in a given strand of multifidus, and I couldn't find that. But what I did find was how many fibers there are in a brachioradialis. So brachioradialis is probably not dissimilar in size to the lumbosacral segments of the multifidus, for sure. It may be even smaller. But the point is, let's put some numbers on it, and that helps to, I think, give us a better context. So if we were to say the lumbosacral segment of multifidus has 250,000 fibers, then of course that split there, the 60-40 split, would mean you've got 150,000 tonics versus 100,000 phasic fibers. So the guy I was having this discussion with, who was saying, so look, that proves that this whole thing about core stability and, you know, activating the inner unit is ridiculous, because he was saying, you know, nearly half of it's phasic anyway. And I was saying, well, you know, that's only the fibers themselves. First of all, the fibers themselves have different characteristics, like we just saw. So these tonic fibers, well, they fatigue late. In other words, they can hold you up all day long. The phasic fibers, they can hold you up, but they fatigue really early. And so these are the kind of patients, if the outer unit is dominant and the inner unit is inhibited, which is what tends to happen with persistent pain, well, then those are the kinds of people that are going to be fine in the morning, but by midday or early afternoon, their pain is going to be coming on quite severely, because essentially they have used up their resources as far as the outer phasic fibers are concerned. They're fatigued. So now they're hanging off their passive subsystem. Okay. So there's the kind of physiology side to it, which is important to understand. But the other element, as I just alluded to, is the motor neurons themselves. So when we look at actually how tonic fibers are fed by motor neurons and how phasic fibers are fed by motor neurons, what you find is that if you've got 250,000 fibers, that would account for something in the region of 15,000 tonic motor neurons going into that muscle versus 200 phasic motor neurons. Okay, so in other words, if you get pain inhibition of the tonic system, you may have lost 60% of your functioning of the muscle, but you've lost 15,000 to 200. You know, so I should have done this as a percentage, but that's a massive percent. In fact, I think I do have a percentage. Yeah, there we go. 99%. You've lost 99% of your motor control, because, as I say, the phasic motor neurons are clumsy and powerful. Okay, they're not refined and coordinated. Now, those of you that are mathematically astute will see that what I've done in this one is I've picked the 500 fibers that are phasic motor neuron feeds and the 10 fibers that are tonic motor neuron feeds. So that's the most polarized version of events. But even if we were to go with the least polarized version of events, then what you'd see is that you've lost 71% of your coordination in that muscle. Okay, so the point being, pain inhibition of the inner unit and the motor control and the way that impacts on people is clearly a big issue. Okay. Now, another thing that people often point to say, well, motor control, isn't that a bit of a myth? Is things like these meta-analyses and systematic reviews on motor control. This one was the Cochrane review. And again, when you read just the headlines, it says there was no clinically important difference between motor control exercise and other forms of exercise or manual therapy for acute and chronic low back pain. So, okay, good. Now, if you're someone who doesn't use motor control, fine. That's your choice. If you're someone that does use motor control and then sees something like this and thinks, oh, okay, maybe I shouldn't do it, which is the way it seems to be interpreted by a lot of people, then that's a misinterpretation of the data. So first of all, the data itself shows that this is what's called a forest plot, and what it shows is that if papers were in favor of motor control, they fall to the left of the y-axis. If they were in favor of other exercise or in favor of minimal interventions, such as, I believe this one was telephone consultations and counseling, and this one was manual therapy. Okay, what do you see? Well, what you see is that when you compare it with other exercise, every study falls in favor of motor control, but not statistically significantly in favor. Okay, how about when we look at counseling and telephone kind of consultations? Well, every single study bar that one falls in favor of motor control, but not statistically significantly in favor of motor control. And then when we look at manual therapy versus motor control, every single one falls in favor of motor control, bar that one, and possibly this one here. So the point is that this is not to throw out motor control. This is to say, okay, well, motor control isn't the only thing we need to work with. We also need to work with counseling, right? And we also need to work with manual therapy, and we need to work with whatever other modalities we can use to help people. Okay. Now, this is another study which people often quote to suggest that motor control doesn't work, and it's exactly the same thing with the forest plots. So when you see the forest plots to the left, that's favoring motor control. When you see them to the right, it's favoring other interventions. So there's the main line there. These are all to the left. There's the main line there. These are all to the left, and so on and so forth. Okay, so this again suggests that motor control is very helpful. So as I was just saying, really what we want to do is we don't want to just jump onto something like motor control or core stability and say that's all you got to do to fix someone's back. What we want to do is we want to work with posture, and we want to work with nutrition and with manual therapy and general exercise, sleep, descending influences, so things like emotions and beliefs around the pain. But we also want to work with motor control because they all contribute and all play their part. So now I think part of the reason that motor control has not played as big a part or hasn't shown up as effectively in the studies as we might have expected is for a number of reasons, and some of that relates back to central sensitization. So things like pain, of course, but also viscerosomatic reflexes, faulty breathing patterns which can occur as a result of persistent pain. These all impact on core stability and on motor control as well. And so if we're not controlling for those in our studies, which we're not, they're not controlled for in any study I've read so far, and I do keep an eye on this literature, then they are going to be confounding variables which are going to impact on the effect of motor control because those things specifically impact on the tonic system, as we're going to see. Also, another factor is that a lot of motor control programs are very poorly designed. They're not even targeting the type 1 muscle fibers in terms of the number of exercises that people do. So you could have the perfect exercise, let's say to activate the multifidus, but if you do it for 10 reps times 10 seconds, you're not even getting into the zone where you're conditioning those muscle fibers. You need to be hitting 3 to 5 minutes of time under tension. But I've never seen that in any research study. So the program design is critical as well. Okay, so, and here's an example of someone who has got great motor control under normal conditions. This girl is a colleague of mine. She's a physiotherapist, and she's a strength conditioning coach, and she's a fitness model. So here's her doing a standard Instagram pose on Saturday 25th, I believe, of November 2 years back. And this is her on Sunday the 26th, having gone out and accidentally eaten some gluten, and she's intolerant to gluten. So this is someone who has lost all motor control as a result of eating gluten. Now, when you look into, and so she suffers irritable bowel syndrome, but if she eats well, then she looks like this, and if she eats badly, she looks like this, and she can't control that. She can't draw that in. It's just shut down, inhibited. So there's 4 factors that are involved in bloating, and the first is the subjective sensation of bloating. The second is the objective abdominal distension that you see here and you can measure. So if you were to measure her waist there, she's probably got about a 24-inch waist. You measure it here, it's probably about 40 inches. Okay, so it's probably almost doubled because, well, you can see it's just massively bloated out as a result of that gluten consumption. The other thing you can measure and objectively assess is the volume of the abdominal contents. You can do that with X-rays or ultrasound, but you can also measure changes to the muscular activity of the abdominal wall as well. So those are the factors that are involved in bloating. And so, and that's the paper that it's from. But the interesting thing is when you do measure using X-ray to see what the abdominal contents is, or what's going on with the abdominal contents, what you find is that a lot of people say, well, this is just gas, right? And it turns out, no, it's not gas, because gas only accounts for 18% of that bloating. So the other 82%, that's almost exclusively down to changes in the muscular activity of the abdominal wall. In other words, inhibition of the tonic fibers that would normally hold tone in the transverse abdominis and in the other abdominal wall musculature. Okay, so this 18% of gas surface that, or the gas surface which accounts for 18% of the bloating, it could elicit some discomfort, but it's not likely to account for objective abdominal distension. Okay, so here's an interesting thing. So when our patients come to see us, they are normally in a state of unconscious incompetence, so they don't know why they're in pain. There's something that's not right, that's the incompetence, but they don't know what it is, so they're unconscious of it. So then, of course, our role is to try and identify what it is. So let's say with this last girl, oh, well, it's gluten. Gluten is inhibiting your abdominal wall. She might come to see us with low back pain, for example, because she can't stabilize her lumbar pelvic region and she's so we can say, oh, well, this is why you've got the back pain, because your abdominal wall isn't activating optimally, and it could be nutritionally related. Okay, but let's just say we're just focused on the abdominal wall for now. So she becomes consciously incompetent. So she's now aware of the fact that her abdominal wall isn't working. So then we teach her, and this is the core stability, motor control kind of literature, we teach her how to activate. So this is how you activate your transverse abdominis, this is how you activate your multifidus, this is how you condition them, etc., etc. And that's where most people get left, okay, is at that point. That's what most of the studies are looking at. What we're not reaching is a level of unconscious competence, which is where essentially you've identified things that may be inhibiting the abdominal wall, such as gluten. Okay, so we need to be working more holistically in order to be able to identify what things are impacting on muscle function. Is it pain, creating central sensitization, which then inhibits the transverse abdominis? Is it irritable bowel syndrome, creating central sensitization, which then inhibits the transverse abdominis and could lead on to back pain or lumbar pelvic pain or sacroiliac joint pain, knee pain even, that kind of thing, because if you can't control the pelvis, then you can't control the legs. Okay, so a lot of these patients, both in clinic and in the studies, are being left at the level of conscious competent. They know what to do, but it's only going to work when they're thinking about it. When they're not thinking about it, so that girl on the previous slide, if you asked her to draw in her stomach, probably at that stage she wouldn't have been able to do it. But give her a day or so, when the inflammation's died down, she probably could have activated her stomach. But if she's not thinking about it, so if she's unconscious about it, it would just bloat back out again. Okay, so that's unconscious. No, rather, that's conscious competence. She hasn't reached unconscious competence yet. Okay, so diving a bit more into the central sensitization, what we can see in this diagram, which we looked at briefly earlier, is that when you've got, if we start at A, which is here, gut dysbiosis. So let's start with that. Now that can cause a gluten intolerance, or it can be a separate entity of its own right. But if you've got an imbalance in the gut bacteria, one of the side effects of that is decreased serotonin output. Okay, and again, there's plenty of research on this. This is not at all hypothetical. It's deeply researched. So decreased serotonin output, 80% of your serotonin output comes from the bacteria in the gut. Okay, so you've got an imbalance of them there, then you've got an imbalance and an inability to produce serotonin. So serotonin, as we know, it gets transported to the brain, and it's important in keeping our mood elevated. And that's why we use selective serotonin reuptake inhibitors when we have depression. Okay, but if we're getting decreased serotonin, then it leads to increased depression. Okay, when we have increased depression, then that increases pain perception. Okay, and it also, now where's the, let's see, D. Okay, so before we get into the depression discussion, we also know that gut dysbiosis is going to create visceral drives. In other words, as you just saw with the girl with the irritable bowel syndrome, that's a visceral drive. It's an afferent drive from the guts into the spinal cord, creating sensitization there and thereby inhibiting the tonic drives back to her transverse abdominis and her abdominal wall as a whole. So then it bloats out. Okay, so that's visceral drives, which then create altered motor control and postural reflexes. Okay, so that's E. Okay, so that's kind of the visceral and the gut side of it. But then coming back up to depression and beliefs, of course, if you're depressed, it's going to impact on your beliefs, your conscious and your unconscious beliefs. But similarly, your beliefs are going to impact both on your emotional state and on your pain perception. So if you believe that your back pain is a genetically inherited thing that you know always going to get because your dad always got back pain, or your mum suffered terribly or had surgery, then that is going to impact on your pain perception. It's going to increase pain perception. So emotions, beliefs, they can create descending pain modulation, which means that essentially you feel more pain. They themselves can create descending central sensitization. And so now the spine is essentially sensitized, and the nervous system is sensitized, which means that the same pain that you get two people that get the same injury, the person with sensitization because they've got gut issues or depression or faulty beliefs, they will feel a lot more pain from the same injury than someone who doesn't have those things. Okay, so exactly the same injury, completely different experience of that injury. Okay, so that's HI. So then we're on to J. Now, of course, when you've got pain, whether that's coming from a peripheral injury or whether it's coming from a visceral issue, then that will sensitize the spinal cord, and that creates ascending sensitized part or nociceptive pathways. Okay, so that means that your pain perception is increased and your pain tolerance is decreased. Okay, now you can have peripheral sensitization and neurogenic inflammation, which can come about as a result of a pro-inflammatory biochemical soup. So this really ties back in with nutrition and with emotions and that kind of thing. But essentially, the message on this side is that there's many things that can contribute to central sensitization. They can be ascending, they can be, if you like, kind of parallel, or they can be descending. And all of those things can contribute to sensitization, lower the pain threshold, lower the pain tolerance, increase your pain perception. And that's what a lot of persistent pain patients are experiencing. Now, on this side, we've got some examples of conditions that are termed central sensitivity syndromes, or a more current term for it is chronic overlapping pain disorders. So I think most of my slides have central sensitivity syndrome, but the more current nomenclature is chronic overlapping pain disorders. But they haven't changed, so they're still the same disorders. So when someone has persistent pain, they often will have one or more of these comorbidities. So things like fibromyalgia syndrome, chronic fatigue syndrome, irritable bowel syndrome, tension type headaches, migraine, temporomandibular joint dysfunction, myofascial pain syndrome, restless leg syndrome, what's this one? Periodic limb movement in sleep, multiple chemical sensitivity, primary dysmenorrhea, female urethral syndrome or interstitial cystitis, or post-traumatic stress disorder, especially if that trauma has occurred in childhood, but it can be in adulthood as well. It's just not so common. So those things are all known to drive central sensitization, And once you've got central sensitization, then A, you're more prone to pain, and B, you're more prone to developing more of these syndromes. So attention type headache, if you suffer with those, you're more likely to develop primary dysmenorrhea, for example, or temporomandibular joint dysfunction, or fibromyalgia syndrome. If you've got post-traumatic stress disorder, you're more likely to mention tension type headaches, or irritable bowel syndrome, or restless leg syndrome, and so on, because they're all part of the same neurophysiological situation. Okay. Now, the interesting thing about this is that when you keep digging into it, you find that there's other things that drive central sensitization, such as depression, vulvodynia, vulvovestibulitis, chronic low back pain, chronic whiplash, osteoarthritis, rheumatoid arthritis, chronic headache, neurosis, conversion V, so these are psychological disorders that create central sensitization or derive from it, stroke, spinal cord injury, osteoarthritis of the knee, of course, you know, really osteoarthritis anywhere, but it's been studied in the knee, endometriosis, injury sustained in a motor vehicle accident, post-surgical pain. So the point being, the more you study it and the more it is being studied, the more things come up as driving central sensitization or being driven by central sensitization. So it's a kind of bi-directional or even a circuit type situation. So here's another example. I've just added a few additional ones that have come up. So it's, you know, this circle is just going to keep getting bigger and bigger and bigger. Okay. Now, in this most recent paper that I've written with Joe Nidges, he said through his research, these are the things that, and so this is kind of refining down those last couple of slides a little bit. So what you can see here is that chronic low back pain is not always caused by central sensitization, but central sensitization is a feature that's present in a subgroup. Okay, so failed back surgery, same thing. Okay, now when it says subgroup, it's a significant enough subgroup to not fall into this category, which is a small minority, 10% or less. So we're talking more than 10%, possibly in some of these as much as, you know, 40 or 50%. Okay. So if we just go down here, we've got chronic low back pain, subgroup, failed back surgery, subgroup, post-cancer pain, subgroup, chronic whiplash is a key central tenet of or sort of characteristic of chronic whiplash. Okay, subacute whiplash is a subgroup, pediatric pain, subgroup, TMJ or TMD, subgroup, migraine, myofascial pain syndrome, osteoarthritis, rheumatoid arthritis, all subgroups. Fibromyalgia and chronic fatigue syndrome, they are, central sensitization is characteristic of those two conditions. Chronic non-migraine headache, there are subgroups that have central sensitization. Irritable bowel syndrome, it's a characteristic of it. And then things like tennis elbow, chronic shoulder pain, even Achilles tendinopathy I've seen, they are present, or central sensitization is present in 10% or less of that, so a subgroup. So that's kind of refining it down. Now this is expanding it back out again, because this is from another paper which essentially looks at some of the self-reported symptoms that are associated with central sensitization. And as you can see, it's quite a list, because this is an alphabetical list. So you'll see that by the time we get to the base here, we're only on chronic pelvic pain, so still on the C's. But there's quite a list of things here, from abdominal bloating, like we just saw in the girl with the irritable bowel syndrome, Candida, Chiari malformation. Now that, of course, is not, as far as I'm aware, is not causing central sensitization, but I think the anxiety associated with it could be enough to create central sensitization. And we head down this list here. I'm not going to read them all out because it would take too long. Okay. And then this list here. Okay. So this is a more exhaustive list, but as I say, bit by bit, we're adding to the list as we understand more and more. Like chronic itch, I was looking at recently, someone, I forget whether it was a patient or there was just something that came up in a paper I was looking at on central sensitization, but people that have these kind of chronic itch type diseases, they have central sensitization. So, you know, there's lots of things that aren't listed here, but that will be added to the list as the research catches up with clinical findings. So one thing that struck me, which I found quite interesting, is that you know, Leon Chato's work way back in 2004, he described the symptoms of a breathing pattern disorder. Okay, symptoms of a breathing pattern disorder, as you can see here: anxiety, panic attacks, foggy brain symptoms, stiff neck, headaches, increased sensitivity to light and pain and sound, palpitations, allergies, bloating, extreme fatigue. Essentially, when you go back to that previous list, they're all listed on here. So it would seem that a breathing pattern disorder is tied in with central sensitivity or central sensitization itself. So you see brain fog, and you see palpitations, and you see bloating and headaches and so on. They're all part of this picture. So I've just got the totem pole here, which is this is one of the check models that we use. So this is a check totem pole, and it's just really to illustrate. We have the psyche at the top of the totem poles. The idea of this is that it's a kind of hierarchy of survival reflexes, is the way we term it. And so you've got the psyche at the top, then you've got respiration, then you've got TMJ, and you've got vision, vestibular, upper cervical spine, then the viscera, pelvis, and then what's called the slave joints. Okay, so of course we spend a lot of our time as osteopaths working on the slave joints, but often it's issues with the viscera, it's issues with the higher reflexive centers, and with central sensitization driven from these that may be bringing the patient in ultimately, or maybe the sort of underlying cause behind their back pain or their knee pain or their hip pain and so on. So at the top you've got the psyche. So the psyche relates to, for example, anxiety, and anxiety can lead to breathing pattern disorders, and breathing pattern disorders can go on to create anxiety. So those two are kind of key elements at the top there. And I'm going to come back to this in a moment when I've gone through another slide or two. But essentially, pay attention to the symptoms that are here and how this relates to the tonic and phasic systems. Okay, so before we get on to that, this is essentially a model that I actually just shared with Joe Nidges, and he said this perfectly kind of illustrates where the thinking is at in the field in terms of stressors that can drive central sensitivity. So you've got physical stressors, could be a physical injury, it could be excess work, it could be poor posture, as we talked about, poor motor control, irritation to the joints, etc., irritation to the discs. Those would be physical stressors. So the idea of the model here is that if you've got excess stresses, then they go in as the red line, but you do need a certain amount of physical stress. We do need to be exposed to gravity. When you put people into an anti-gravity environment, they don't do so well. We need to do exercise to stay fit and healthy and keep the systems working properly. The same with chemical exposure. We've got optimal levels of chemical or biochemical exposures, and we've got suboptimal if we have too much of them. Electromagnetic, we need the electromagnetic drives from the sun, perhaps not so much from mobile phones and 5G and all the rest of it. Okay, so that's something to bear in mind. Psychological stresses, nutritional stresses, thermal stresses, they all go into the bucket that is the human body. So this is representing the human body, the bathtub of the human body, if you like. And so when we have a certain amount of stress, that's good because we can maintain homeostasis, and we have a high tolerance for further stress and for exercise and so on. But when we have too much stress and we start going to this orange zone, then we start to become a little bit symptomatic. This is where we might see a patient or two. But most of our patients are going to come to us when the symptoms are getting too much for them and they're up in this red zone. Okay, so what is it that's bringing to them? Is it really a facet joint or a disc or a sacroiliac joint or a hip that's restricted, or is it actually let's say an irritable bowel syndrome that shut down the motor control around the pelvis, which means that they're using the outer unit more, which creates more compressive force through that hip or through that sacroiliac joint. It fatigues early, which means then you're hanging off of the passive subsystem, which puts stress into the joints themselves and into the ligaments. So they come in to see you normally with an injury to the passive subsystem of the joint, and we treat the joint. But is that really what caused it in the first instance? So if we can understand the physiological loads that drive these issues, then we can get much closer to the cause, as well as helping people to move beyond the pain and to realize their potential as a human being. So back to the inner unit and outer unit. This is just a kind of schematic diagram of it. So the inner or the more tonic fibers are depicted in red here, and they're deeper, whether that be in the spine or whether that be around any given joint in the body. Okay, and so we can kind of play that game all the way around the body. The more peripherally you go, the more phasic, so they're whiter. But in and around the joints, you'll find more tonic fibers. Okay, so there's the human body. Now, if we have someone who has, let's say, irritable bowel syndrome, they might have a bladder issue or a uterine issue like primary dysmenorrhea or cystitis. They might have low back pain. They could have a headache. All of those things create central sensitization, which impacts on the tonic drive. So you see these tonic drives coming from the spinal cord here to the tonic system. So what that does is it means that the tonic system is relatively inhibited and you're dependent on the phasic system. Now, the thing with the tonic system, if you remember a few slides back, the tonic system is a system that fatigues late. In other words, it's aerobic. It doesn't produce lactic acid. Okay, so essentially you can keep using your tonic system all day long. It's not going to fatigue if it's active. But when it gets inhibited by multiple drives into the nervous system, and often it is, just to be clear, the original research on central sensitization suggested that you really needed pain to be present for central sensitization to occur. But what the more recent research is showing is that you don't even need pain. You need to have multiple sub-threshold drives that together cumulatively can create a supra-threshold drive. Okay, so you could just get a little bit of bloating that you don't even really notice. You could have a little bit of irritation in a joint in the back, and you might get an occasional headache or an occasional shoulder pain or cystitis or something. But they're not anything to write home about. But when you combine them, they create central sensitization. Okay, now, if that sensitization is inhibiting the tonic system, which we know it does, then you're dependent on the phasic system. Now, the phasic system creates compression through the joints, so it irritates the joints. It creates a backlog of waste metabolites, so things like lactic acid and pyruvate. Okay, so now you're getting a lot of achy joints. You're getting a lot of achy muscles with tender points in them. You're getting fatigued early. What is this starting to sound like? Okay, I think you're all following, hopefully. But we're talking about chronic fatigue syndrome. We're talking about fibromyalgia. We're talking about all of these conditions that people have gone, well, we don't know what's going on. For me, what seems to fit all the pieces of the puzzle into place is central sensitization. And so, if we can understand this, it's not a case of treating someone's trigger point with someone who's got chronic fatigue syndrome. That's really not going to cut it. We've got to go back to their physiological load, to what's stressing them and creating the central sensitization. Okay, so to give you an idea of how prevalent this is, well, if we look at irritable bowel syndrome on its own, 11% of the population experience irritable bowel syndrome. Inflammatory bowel disease, it's 0.33%. Temporomandibular joint dysfunction is somewhere between 5 and 12%. Okay, dysmenorrhea is somewhere between 16 and 91%. Of course, that's female, so it's 8 to 40.5%. So that's the lower end. Where I've got blue and yellow, if I were to take the higher figure, it would take us to here. If I was to take this higher figure, it would take us to here, and so on. But if I take the lower figure, then I would, just to not overplay it too much, then this is where we end up. So you do sort of symptom by symptom or condition by condition, you end up well beyond the 100% of the population experiencing conditions that can drive central sensitization. And this is just with some of the core conditions. It's not mentioning things like breathing pattern disorders and small intestinal bacterial overgrowth and surgeries and fatty liver disease, ischemic heart disease, angina. These are all things that can sensitize the nervous system centrally, but they're not even accounted for. So my point is that a lot of our patient base are going to have one or more of these things, including the pain that they're presenting to us with, and it's quite likely they're going to have central sensitization. So here's a quick example of lateral epicondylitis. So quite a common thing to see in the clinic, but it can be linked in with central sensitization. And with allostatic load. And so I'm going to talk a bit about that because that's really what drives central sensitization. So this study was done on nearly 2,000 workers from 25 diverse industries. They were looking at the risks of lateral epicondylitis associated with cardiovascular disease risk. And what they found was that people that had markers of cardiovascular disease had a 6-fold increased likelihood of lateral epicondylitis. Okay, so then they looked at carpal tunnel syndrome, and people who had cardiovascular risk factor markers, they had 5 times the likelihood of developing carpal tunnel syndrome. Then they looked at abnormal median nerve conduction, and this was 8 times the level in people with cardiovascular disease risk factors. They found the same with shoulder disorders, although they didn't specifically specify which ones. In other research that I've found, it's mainly rotator cuff tears and pain. Okay, so the interesting thing here is that the heart, as we know, refers into the arm. So the question here is, well, could this be central sensitization predisposing to pain in the wrist, in the elbow, in the shoulder? And of course, potentially it could be. There's other risk factors associated with development of these conditions, such as increasing age, obesity, low social support, and genetics. And it just so happens that they are also related to increased risk of central sensitization as well. However, there's a little fly in the ointment, and that is Achilles tendinopathy. And so Achilles tendinopathy is also higher in people with cardiovascular disease risk factors than, it's higher in people with those risk factors. So the point being that, you know, of course, it's a nice story and it fits nicely with the neurophysiology that the heart might be impacting on the arm, but it's quite unlikely that the heart will be impacting down on the Achilles directly. But what it does do is it shines a light on something a little different to consider. And that is that allostatic load is probably the key element. If we go back to this previous slide, excuse me, allostatic load is essentially, you know, as you'll all be aware, it's where the body moves out of homeostasis because of stresses imposed upon the physiology. And so allostatic load, which we've got, you know, in the title here, that is what precedes central sensitivity. So if we look at this next slide, if you imagine someone with heart disease, and we know that heart disease or markers of heart disease, things like high homocysteine, what else was it? I think you know, various cholesterol measures and so on. These people have a higher risk of the various conditions we just looked at there. Now, why would that be? One possible reason could be central sensitivity, but another reason is if you think about what happens with heart disease, you start out with practically no symptoms. You've probably just eaten, let's say, you know, a deep fried fatty meal, and that's enough to create a bit of inflammation in the arteries. Okay, now normally the body heals up pretty well from that, but if you keep repeating that habit, or you smoke too much, or you drink too much, or you eat too much sugar, you know, these are all things that damage the arteries and create inflammation in the arteries. So bit by bit across a period of time, what happens is the artery wall starts to get irritated. So we've got the allostatic load is the irritation on the artery wall. Okay, and so then the next thing is that you start to get cholesterol being laid down to try to heal the intima of the artery. Okay, and so then that starts to affect the flow of the blood through, and bit by bit you'll start to get to a point where with the heart you might start to experience a little bit of angina or shoulder pain or arm pain after you've exercised hard, after you've walked up a hill or climbed the stairs and you're breathing a little heavy. So now you're starting to get essentially afferent drives. So prior to the afferent drives, we just had allostatic load. We just had all of these various things going on to create the process of atherosclerosis in the body. But then we start to get afferent drives from the heart in the form of, what did I just call it? I've got a brain block. I was going to say palpitations, not palpitations. It'll come back to me in a second. But what is it? Heart pain. Someone shout at me. What's the name for heart pain? Ischemic heart pain. Anyway, I don't know. I'll try not to think about it, and then it'll come back to me, I'm sure. But so you get what I'm talking about. So allostatic load precedes the central sensitization or central sensitivity, and then if you keep getting that angina, that was the word I was looking for, then it will create sensitization at the cord, and that then leads on to more pain. And ultimately, if you continue with the same habits that drive the allostatic load, you will end up with a heart attack or heart disease. Okay, so the point being is that this seems to be the process through which things go. And then you start to look at the previous slide and say, well, okay, so if there's allostatic load that precedes the heart issue, well, then it also is going to be creating issues in the blood flow to the periphery. It's going to be creating more of a pro-inflammatory state in the body, which is the common pathway to chronic disease, is inflammation. And so no doubt, or no surprise rather, that the Achilles can be affected by the same markers that affect cardiovascular disease, because essentially they're reflections of allostatic load. Okay, so how do we assess allostatic load? Well, the unfortunate thing is assessing allostatic load isn't that easy. There's a lot of research studies out there, and you don't have to read this. I'll read off the key elements for you. But essentially, in this paper by Zilioli et al., they looked at over 1,000 people with allostatic load for a series of biological and anthropometric measurements designed to screen 7 physiological systems. And this is fairly standard. I've looked at a lot of papers on allostatic loads, or what is sometimes called physiological load. And so what they looked at was they looked at cardiovascular functioning using systolic and diastolic blood pressure arrests and resting pulse. They looked at lipid metabolism, including HDL, LDL, triglycerides, body mass index, and waist to hip ratio. They looked at blood sugar, glycosylated hemoglobin, fasting glucose, and the homeostasis model of insulin resistance. They looked at chronic inflammation by looking at things like C-reactive protein, fibrinogen, and serum samples of interleukin-6, etc. They looked at SNS activity, including overnight urinary measures of epinephrine and norepinephrine, PNS activity using heart rate variability, and HPA axis activity using urinary tests for cortisol and DHEA. Okay, so you can see that's the kind of thing that in research studies they're using to assess allostatic load. But that's not all that practical for us in the clinic or for our patients. So what I would recommend, so first of all, the way I would work with allostatic load, and this is a check model, and the reason I put this in here is that we talk about it in the papers that I showed you, the Ghost in the Machine papers, but also it's just a very useful model to look at, are we covering all of our bases with persistent pain, with central sensitization, in fact, with any condition. So we want to look at how are they moving? Are they moving well? Are they able to move? Are they moving functionally? How are they eating? Are they eating well? Are they eating whole foods? Are they eating foods that are not pro-inflammatory? Are they eating foods that are not going to disturb their sleep? They're going to allow them to repair effectively. Okay. How about sleep and rest time? Are they getting enough sleep? Most people aren't getting close to enough sleep, so they can't repair. It's impacting on their hormonal function, and then that then impacts on their desire to exercise. It impacts on their dietary choices and on their pain levels. And then doctor happiness. Are people anxious about their pain? Are they depressed because of their pain? Are they happy in their relationships? Are they happy in their career? What are the major stresses on them, and how can we help them to manage those stresses? So that's just a nice kind of way to break down the key elements that people can address when they've got persistent pain and central sensitization. And we may look at that again briefly in a moment. So in terms of a tool to actually assess for allostatic loads, what I would recommend and what I use, and this is from the Czech training as well, is something called a health appraisal questionnaire. And the health appraisal questionnaire allows you to screen 28 different organ and glandular systems. So this is just sort of page 1 of the health appraisal questionnaire. And so what it does, as it's, the name suggests, it's a questionnaire you send to your patients. The patients then go through the questionnaire. It takes about half an hour or so. And what you get is you get an overall stress score. Okay, so the lower, the better. This is essentially your allostatic load. So this person had very high allostatic load. Okay. Then you look at each of the systems broken down. So you've got the gastric system. She's scoring high here. Gastrointestinal inflammation, very high. small intestine and pancreas, high. Essentially, this patient is high in pretty much everything. Okay, so this is someone with high allostatic load. Now, I just had a patient this morning who was scoring down here, and he was low in gastric function, high in gastrointestinal inflammation, high in small intestine, but everything else pretty much throughout was low. Okay, so the point is that once you understand where the stresses are on the system, then you can give nutrition, lifestyle, exercise advice to help people to address the key elements that are creating load on their system. And by unloading the system, then you unload the sensitization, and as the sensitization comes down, so then the motor control improves, especially if you're giving them the right kinds of exercises. And as the motor control improves and their nutrition and biochemistry is improving, so then their pain will start to drop, their sleep will improve, their breathing pattern will improve, and so on and so forth. So this is page 2 and 3, and what you see here is you see blood sugar regulation. So this patient, she was in quite a bad way. She scoring high on pretty much everything here. You can see that we also have a section here for mood. Okay, so depression, anxiety, and anger. And then we move on to urological system. She's got her only score in the medium so far. She did quite well on her prostate, which is good. Reproductive tissue inflammation was low, so that's good. And then finally on the last one, hormone balance was pretty good, but she scored quite high on those other columns. So no surprise that in total she has high physiological load or allostatic load, and this is someone who's likely to have central sensitization. Now, there are other tests you can do. This here, by the way, is just like an alternative lens you can look at the scoring through. So this is the traditional sort of chakra system of Ayurvedic medicine, and it's just showing you which of the organs from the 28 different organ and glandular systems have scored high in which zones. So, you know, if you're open to that and you're more sort of let's say, yeah, open to esoteric or energetic based approaches, then that can be helpful on that front. But if you're looking at it more anatomically and physiologically, all this is really doing is showing, well, this person has a score of 10 in this kind of solar plexus area, and that is a reflection of the organs that are coming, you know, being fed from this part of the spine. Okay, and so therefore this is where your osteopathic treatment may want to focus. Okay, she's also got a lot going on in this lumbar spine area, and she's got a fair bit down in this sacral area too. Okay, so those are the kind of the key areas. She's not so bad around the thoracic spine, she's not so bad around the cervical spine, etc. Okay, so that's an alternative lens you can look through. So yes, I just wanted to throw this in actually as a kind of bonus, I suppose, because this is from the upcoming paper I've written with Joe Nidges, and what it shows is that another thing you can do for people with central sensitization is you can increase their BDNF secretion through exercise or through fasting. So we talked about diet here, and we've got Dr. Movement as well, but through exercising, and especially novel movements, but also through fasting or ketogenic diets, what you can do is you can increase your BDNF secretion, and you can direct it into essentially the right places in the body, so that you're using the BDNF, which is brain-derived neurotrophic factor, so that what that's doing is it's helping you to move better, it's helping you to think better, it's helping you to learn better, etc. And what it does is it directs the BDNF away from pain facilitation. So BDNF is like a double-edged sword. If you are in pain, then the BDNF just serves to increase your pain. It helps you, it kind of facilitates well, as you see, it's called brain-derived neurotrophic factor. So essentially it facilitates neuronal growth. So if you're feeling a lot of pain, you'll use your BDNF to feel more pain, okay, and to remember the pain better. But if you can channel your BDNF into exercise and into learning, so pain neuroscience education, looking at pain as a teacher, so contemplating, what could this pain be teaching me? Could this back pain be teaching me that maybe I need to address my irritable bowel syndrome? You know, is that the message in this in this pain situation? Is it teaching me that I need to work on my emotions more and address that trauma that I experienced as a younger person, that kind of thing? So there's often, like I say, a kind of lesson in the situation that people can use to direct their BDNF into a learning and a positive way of utilizing it and creating new neuronal growth. Okay, so that's just a little teaser from the upcoming paper. So I know we've run over a bit, although I think we were supposed to be going till past, but I'm cognizant I need to let you get some questions in. This is just a way of coaching patients essentially through how their musculoskeletal problem that they come in with to see you with. Often it's not just a musculoskeletal problem. Often there are gut issues associated, or blood sugar issues, or liver issues, or whatever. So with that understanding from the health appraisal questionnaire or from your case history, you can show how the organs may also be creating stress on the musculoskeletal system. You can also show how the hormones may be creating stress on the musculoskeletal system, and indeed on the visceral system. So a simple example, pain increases cortisol output. So that's a hormone, of course. Now, if cortisol's high, then what it does is, first of all, it shuts down digestion, which means that you can't digest as effectively. So how are you going to digest the nutrients to repair your tissues? Second of all, it compromises repair if it's chronic, because it functions very much like cortisone when you're chronically exposed to cortisol. And also it impacts on emotions. So it makes you a little bit more angry, a little bit more agitated, etc. So you can see that pain on its own has this hormonal effect, which then impacts on everything else. Okay, you can argue that pain is a limbic emotional component. There could be other limbic emotional components from the person's past or their current situation, which may need emotional counseling or perhaps even referral to someone. But these things will all impact on hormonal outputs, which impacts on visceral outputs, which impacts on musculoskeletal function. It's just a nice little diagram that you can draw up for your patients and say, so that's why, as much as you come into me with back pain or knee pain, we also need to be looking at the organs, we need to be looking at the hormones, we need to be looking at the emotions as well, because they all interact with one another. Okay, so it's a nice little teaching tool. So just to round off, now that health appraisal questionnaire that you saw, that is something that unfortunately I can't give away because it's not mine to give away. It's developed by actually Metagenics, Jeffrey Bland's group, and Jeffrey Bland is kind of considered the forefather of functional medicine and functional diagnostics. But the Czech Institute have permission to use it. Now, if you like this way of working with the body and you like what you've seen today, this is the kind of thing that we teach in the Czech system. Now, this is not a promotion for the Czech system per se. Of course, I work in the Czech system. I work as a Czech practitioner. I teach for them. I think it's a fantastic system. I love the results I can get through working with it. But the point being that if you want to be able to get access to that health appraisal questionnaire, one way to do it is to train up as a holistic lifestyle coach. And so you've got the level 1 that you can do online, level 2 you have to do in the class. That's where you get that health appraisal questionnaire given to you, is in the HLC 2. Okay, so that's just a bit of background if you like this and it's something you'd like to follow. But if you don't want to do that, then what I've done is I've created it as a product on my website, which the patient can go to. They can download the screen for £8.99. Okay, so it's quite affordable, and it gives them that entire printout. It doesn't have anything about the chakras. That's deliberately removed just in case that upsets people. So it just gives them information about their 28 different organ and glandular systems. Okay, what they can then do, so I'll just put this up. So the patient can be referred for physiological load screen at this URL. They can fill it in. Like I said, it takes about 30 minutes. They'll then receive this report as a PDF, which leaves them with 3 options. So the first option is to come back to you so you can go through it. And at this time, with the COVID and with potential shutdown going on longer, this is a great tool that you could actually write out to your patients to say, look, particularly the ones that have persistent pain or multiple health issues, and say, look, there's this screening tool which you can access for quite a low price, £8.99. You can download it, and what it tells us is it tells us your physiological load or your allostatic load, and then we can start to address the key elements that are scoring high. Okay, so if it's the digestive system, we can start looking at digestion, and we might give some supplements, or we might give some nutritional advice. You might refer to a nutritionist, depending on how you feel and what you feel your own scope of practice is. So that's the optimal outcome, is that they can do that. The second possibility is that for each of these components of the questionnaire, I'm putting together videos. I've done about 18 of them, 18 out of the 28 so far, but they will be available on my website in the next few days. So essentially, a patient can come along and they can do their own test. And if they want to, let's say they just score high in a couple of these categories, 2 out of the 28, they can just download a couple of the videos for a couple of pounds each. But if they have multiple things that they want to download, they could either download all the videos, or most likely they'll want to come back and consult with you. Then, of course, the third option is that they can do self-research. So they can just look into, they score high in certain categories, and they can research that themselves. If their blood sugar's high, they can go and look at that online. So it's a simple tool, which gives them quite complex, quite detailed information. But the idea is that they can then take that back to you, and you can consult with them online using something like Zoom or GoToMeeting or Skype, whatever works best. And I do this with my clients the whole time, and I find it a fantastic way to work. So hopefully that gives you, a bit of background on central sensitization, B, a bit about what also seems to cause central sensitization, which is essentially physiological load and allostatic load, and then C, how to assess for allostatic load. And this doesn't just apply to pain, this applies to health in general. So the COVID situation at the moment, of course, the lower your physiological load, the better you're going to cope with a new stressor, such as an infection. The higher your physiological load, the more of a challenge that is to the system. So again, I'm not touting this as a treatment for COVID. I don't think that would be the right thing to do, but it does give you insights into why people might get things like multiple infections, or why they might be prone to certain recurrent injuries or recurrent bouts of depression, that kind of thing. If you can decrease that overall physiological or allostatic load by working through those components that score high, then you'll have a healthy, happy, and functional patient that's able to realize their potential as a human being. So that's the end of the session. So what I'll do is I will just have a look to see what questions have come in. If you've got questions that you haven't typed in yet, feel free to ping them in now. So let's see. So yes, first question was about seeing the slides. I have to be a little bit careful with some of them because they're not my own. Most of the okay, I can see there was a few issues with connectivity. Most of the slides are my own, so I'm happy to share my own slides. But let's see, what else is there? Could you send me the link for the paper? Yep. So the link for the paper, that's no problem. That was about the sagittal spinal curves. Do you think many studies have negligentiated the role of central sensitization? Let me see if I can actually get this full message to appear. So this is a message from Philippe, and I can't see the full message for some reason. Let me just see if I can actually open the whole thing up. I can't seem to see it for some reason. So you're saying core stability's therapeutic approach is doomed to fail. Oh, here we go. I think, okay, right. I think I can see it now down the bottom. Okay, right. Yes, good. Okay, so you think studies have negligentiated, I don't know if that's a word, or maybe neglected the role of central sensitization, and this is why the results might be heterogeneous. Yes, that is what I'm saying. I'm not just saying, so I think this is relating back to the sagittal spinal curves discussion. I think, or maybe it's relating back to the core stability. Yeah, it's in that region of time. So I'm not sure which one you're referring to, but either way, central sensitization is not accounted for in these things. And the issue with the sagittal spinal curves is largely that they're assessing for a heterogeneous condition, but using a homogeneous assumption. So they're calling it low back pain, but we all know that there's so many things that can contribute to low back pain, not just posture and not just one posture, but if someone's out to the side, that's going to impact on how their back functions. If they're too far forward sagittally or too far back sagittally, or they're twisted, these are all going to impact physically on the function of the spine. And so that's not being accounted for in the study. What it's looking for is a correlation between, is low back pain associated with a specific posture? And it's like, no, it's not. So there's an issue there. Okay, so that was one thing. The next one from Jeff, let's see if I can get that to appear. Okay, so you're saying that core stability as a therapeutic approach is doomed to fail owing to the reflex inhibition of the actual core muscles with over actuation of the prime movers, so the balance never gets addressed. Yeah, to some degree. I mean, it's not to say that it's doomed to fail, but it's that I mean, for example, Julie Hyde's put out a paper back in 1996 that showed that even 12 weeks after the pain has gone, that the multifidus hasn't reactivated. So in other words, unless you actually go in and physically rehabilitate that muscle, it seems like the multifidus doesn't switch back on again after an episode of pain. Now, I think it could do. I think, if you look at it in a look at the situation in a natural environment or an evolutionary environment, then I think what we understand of how that muscle reactivates, it's where you get extreme balance challenges that the tonic system really switches on. That's why things like Swiss balls and Bosus and foam rollers and all those kinds of toys and gadgets have been somewhat helpful. Rocker shoes was something that Yandi used, wobble boards, etc. They facilitate the tonic system, and so that can be helpful in reactivating. And I think in a natural environment, for example, some of the indigenous North Americans would run in a dried out riverbed to treat back pain. And so essentially it's like sand running, So what it's doing is you're moving across a surface that's a little bit unpredictable, a little bit slippy, and that's going to activate the tonic motor neurons. If you think of a primate example, climbing up a tree, swinging through a tree, having to climb a tree to get away from something that's chasing you, those kinds of environments, or indeed, having to run and change direction quickly, those are the kinds of things that will tend to switch back on the tonic system because of the lack of predictability. Thank you to everyone who shouted angina at me, by the way. I was just reading down the next comments, and there's like 7 anginas, like angina, come on. Anyway, thank you for that. So next one. I guess, just to finish off on that last point, what I would be concerned about is that if, you can give the right exercises and again, ideally you progress them, you take them from more isolation to more integration, but what you also have to be thinking about is what other things could be inhibiting. So it's not just pain, it's viscerosomatic reflexes, which I think is where as osteopaths, where we're so versed in that way of thinking, that makes it easy for us to have that in the back of our minds when we're working with people with core stability or back pain or whatever. Okay, so next one. Do you know if there are relevant studies concerning the relationship between manual therapy and changes on sleep pattern? Functional training teachers have found some relations on them, and they want to focus their training to improve sleep patterns in people who needs more sleep, I guess. So relevant studies concerning the relationship between manual therapy and changes in sleep pattern. I'm not 100% clear what's being asked there. So I think probably what's being asked is can manual therapy help with sleep patterns? And I think, I haven't seen any studies on it, but the moment you start to improve pain, you start to reassure people, then that always helps with sleep. So I think, what we do as manual therapists is fantastic. We reassure people, we put our hands on them, we calm them down, we completely reduce their anxiety, We often give them hope, so we reduce their depression. Many of these things that can contribute to central sensitization, we do a lot of it. Some of us do exercise as well, some of us do nutrition as well, but my understanding of central sensitization is that if you don't do nutrition, then find a good nutritionist to work with. If you don't do exercise, find a good trainer to work with. You know, it surprised me how knowledgeable some personal trainers are. I think, you know, we kind of, as people that have done medical style degrees, we think that we are far more trained than someone like a personal trainer. But some of these guys, they've got master's degrees in strength conditioning, and they've done nutritional qualifications, and they're expert sort of movement assessors. And find a good personal trainer or a good strength conditioning coach, and they will be fantastic for your business. A Czech practitioner is, you know, when people ask me what a Czech practitioner is, I say, well, it's kind of like bridging the gap between strength conditioning and manual therapy. You know, it's like that Czech practitioners have the knowledge of how this all fits together. They have tools to work with it. So that could be someone that you could work with if you don't feel comfortable addressing it all yourself. Okay, so then next one. Do you think fibromyalgia or chronic fatigue syndrome are pathologies by themselves, or are they simply part of the general adaptation syndrome? I think hopefully I covered that in as much as I think, yeah, absolutely, it's part of the general adaptation syndrome. It's your body's trying to respond. So, you know, for example, when you are under stress, then your breathing rate goes up. When your breathing rate goes up, it creates more anxiety, and then the anxiety creates a higher breathing rate, and because of the breathing rate, you become hypocapnic, and because you're hypocapnic, you start to produce more lactate and more pyruvate in the muscles. So then you start to get towards a point where you're starting to get achy muscles and tender muscles, and the pain can shut down the tonic fibers, and because you can't use the tonic fibers in the muscles, now you've got to use the phasic system, which increases the amount of pyruvate and lactic acid. And so you can just see you get caught in a cycle, and the pain creates more anxiety. And, you know, really that's what we're talking about here. And, you know, it's not to underplay how complex it is, because it could be like a food intolerance, like the girl we just saw with the gluten intolerance. She obviously is reacting very strongly to gluten. And even someone who just reacts a little bit to gluten, their pulse rate will go up instantly the moment they put gluten in their mouth. It's a well-known clinical test. Is the pulse test. So, you know, grab a bit of croissant, put it in your mouth, and see what your pulse does. If it stays the same, you're almost certainly good with it. But if your pulse jumps up, then you're almost certainly not good with it. And what that does, that test, is it just gives us an example of what's going on when we eat the food we're intolerant to. We're going into a stress response. Okay, now that food stays in you for somewhere between 12 to 72 hours. That's the sort of transit and retention time of foods that we eat. So essentially your body is now under stress for 72 hours after you've just eaten that gluten. Okay, so when you think how many people are eating foods that they're irritated by and intolerant to, that's going to be a huge driver of central sensitivity, you know, central sensitization. Okay, so a few more questions. In fact, there's quite a few more questions. Okay, so let's see. So practical session. Yeah, I guess we could do a practical session. You think of an online practical session, or you actually mean a practical session? I could possibly do something online. It'll be a little tricky. I have to get a model in. Maybe I could use my daughter, or my wife, or my son, or something, or the dog. Yeah, something we could consider for sure. Next question is, when assessing allostatic loads, how do you gather data for each organ, colon versus intestines? So there you go. That's how I do it, is using the health appraisal questionnaire. So that health appraisal questionnaire, just so you understand, is kind of a first line tool, if you like. So I don't see patients until they've filled in that questionnaire. That's the way I work. So I get them to fill in a series of questionnaires before I even tell them whether or not I think I can help them. Okay, so it's a little bit different to how I used to work when I was more sort of osteopathic. But the point I was going to make is that the questionnaire tells you where the stresses are. And let's say, you know, the colon scores really high. If you think it's relevant and you think that it would help the person and they are up for it, then I would then do something like a comprehensive digestive stool analysis. So that's a lab test for their colon function. Now, the reason that questionnaire was developed is it was developed by Metagenics, because they were the people that developed all of this functional diagnostic lab work. Okay, and the reality is, if you came to see me and you had, you know, let's say fibromyalgia syndrome, and I said, well, you know, we've got these 30 tests you can do, but it's going to cost you £10,000, and it's going to take a month to get all the results, and it's going to take, you know, 20 sessions to go through the results. It's not going to work. So the health appraisal questionnaire is designed to be a quick, short questionnaire, relatively half an hour or so, and it allows you to identify where the key stresses are on the system. So then once you've got where the key stresses are, you can either just address them without lab testing and then redo the health appraisal questionnaire in, let's say, 3 months' time. Or you can do a lab test so you know exactly what you're dealing with, and then you can make your interventions, and you can, again, either retest with the lab test or retest with the health appraisal questionnaire. Okay, so that's how I use that. Next thing is, do you all have to be already qualified to do that course, or can you still do it as a final year osteopathy student? You can do that course. There are prerequisites for all of the check courses, but they, for the holistic lifestyle coach, I think it's just to read a book, so it's not exactly a tough prerequisite. But yeah, so you don't have to be qualified as an osteopath to do the courses. You get all sorts on the courses, from you know, qualified nurses to you know, I had a guy who was an organic house builder from Sweden, so no medical background whatsoever. And you get even, you know, surgeons on the course, and pharmacologists, you know, real mix of people. So it's quite fun to do the courses. Let's see. Next one is, if we want to see the questionnaire, can we buy from you to understand what is in it? Yes, absolutely. And I don't know if you saw the article I wrote. So that's, if you've got Osteopathy Today, that's the article I wrote, which probably will give you a bit more information, you know, a few other thoughts. But what I say at the end of that is that the first 20 people to drop me an email, so that's to matt@mattwallden.com, pretty easy to remember, so Matt with 2 T's at mattwallden.com, I will give you access to the questionnaire for free. So if you want to drop me a line, just all you have to say is HAQ on it, or whatever, and I will return an email back so you can access the HAQ and you can do it yourself. Beyond that 20, I've only got a certain allocation and a certain amount of time, so I'll have to charge for them beyond that. But if you guys that are on the call today want to drop an email to me now while you're online, then you can get one of those for free. Otherwise, you just buy it from my site, again, mattwallden.com, and you just search for physiological load, actually, physiological load. Okay, and that will bring it up. I'm still reworking my website so it's more accessible and logical to find your way around. Okay, there's still quite a few more questions, so I'll keep going with it. But if I know some of you may have to go, but I'm going to keep working through these questions. This is going to be, has been recorded, and it's going to be up on, I believe, the IO's YouTube page. Okay, so it says, would you give the health appraisal questionnaire to all of your patients or just to those with a diagnosed chronic overlapping pain disorder? I give it to all of my patients. That's just the sort of process that I have gotten into now. So you know, it gives me a really good understanding of what stresses they're under, and therefore what kind of level of approach they're going to need. So if someone's got very low physiological load and they want to run a marathon, I may help them in designing a program to run a marathon. If someone's got very high physiological loads and they want to run a marathon, I might say to them, I think you should probably start out with, you know, rebuilding your house, as it were. You know, let's get your energy levels up, let's get you stable, let's get you functioning well, sleeping well, eating well, and let's focus on the marathon for next year. So in the interim, maybe we'll do a 5K in 6 months' time, and we'll do a 10K in 9 months' time, and then, you know, the marathon we'll go for next year, something like that. So it really helps you to hone your approach, no matter who you're working with. Excuse me. Okay, so is there a way of getting a CPD certificate? I expect there is, but I don't know. How would a regular patient answer some of those questions? They seemed a little difficult for a non-clinician. I'm just trying to work out which questions we're talking about. I mean, the questions on the health appraisal questionnaire are things like, do you get bloating after meals? Do you, you know, does food repeat on you? And it's one of those, what do they call them, where it's kind of, you know, never, occasional, frequently, always, one of those questionnaires. So it's pretty simple if that's what you're talking about. Yes, you get to see this again. Will this webinar be available to access and rewatch? Yes. Are your patients receptive to this? Do you find that there's resistance to lifestyle change because PTs have an expectation of being more passive in their recovery when they visit an osteopath? Our patients are more passive. Yeah, you know, when I first started doing the check approach, I was obviously working as an osteopath fully at the time, started to integrate the check system into what I was doing. And so what I did with my patients was I just said to them, look, you know, if I've seen you 2 or 3 times as an osteopathic client or patient, and I think your condition would respond really well to a more in-depth assessment. Now that is 2 hours or it is X amount of money or whatever, but I think what it does, it gives you the tools to get yourself better more effectively, and you become less dependent on me. And most people, I would say probably 70 to 80% of people said, yeah, I'd like to give that a go. But I did have maybe 20% of people that said, no, I'm fine. I just want to have the treatment and that's it. So for quite a few years, I was still seeing, and even now I still see 1 or 2 patients just for pure osteopathy. But most of my patients, they come in for these more holistic, comprehensive programs. And the osteopathy fits into that. So I do treat them, of course, but they're often having nutritional coaching and emotional coaching and lifestyle coaching and so on. Okay, next question is, how do you personally explain to a patient of yours how central sensitization works? Okay, so I normally just explain a little bit about how, I mean, it depends on what they're presenting with really, because of course you want to make it relevant to them. So if they've got bloating, then I would say, well, this is how it works, you know, and I would essentially run through what I just described really with that patient. I might even show the image of the girl with the bloating and irritable bowel syndrome, explain how the sensory nerves get excited when there's inflammation in an organ, and that excitation is passed into the spinal cord, and it creates something called central sensitization in the spinal cord. And that sensitization is essentially something that then can inhibit the tonic musculature, if that's relevant to their case. I might explain that. But also I would explain that, you know, it can lower their pain threshold, increase their pain sensitivity, etc., etc. So that's how I would explain it, generally speaking. But I try and tie it in, obviously, with what they are experiencing. Let's just see. So Jamie said, is there an evolutionary driver to abdominal wall inhibition from GI irritation? Where does this happen functionally? Yeah, you know, it happens functionally because you don't want to irritate something that's already irritated. So, you know, when you've got an inflamed gut, the last thing you want to do is to compress it. You know, you want to not compress it whenever anything's painful. That's why, again, the inner unit, when it gets shut down, the primary role of the inner unit musculature, or the tonic musculature, is close into the axis of rotation of the joint to compress the joint. So when you're in pain, you let off the pressure valves, decompress the joint, and it feels a bit better. That's the inhibition that you get of the inner unit. Same with any kind of gut inflammation, uterine inflammation, bladder inflammation, or indeed, you know, when you need to go to the toilet, you do the same thing. So this is one thing that can cause motor control issues. If a patient is the kind of patient that will only go to the number 2 once a day because they refuse to go when they're at work, and they hold on to go for a week because they don't like using the facilities at work, that's a real problem, because you're getting signals from the sensory receptors, the baroreceptors within the bladder or within the colon, to say, I'm full, I need to evacuate. And the only way you can't decrease the firing of those receptors internally, because you've got the fecal matter or the urine in that structure, so you can't decrease those signals. The only thing you can do is take pressure off from the outside, so you inhibit the abdominal wall to decrease pressure on those organs, and you end up with an inhibited abdominal wall. So yeah, there's sort of mechanisms and evolutionary rationale for why these things get inhibited. Okay, here we go. So could you give an example of multifidus activating exercise alongside repetitions or duration of movement? Yeah, okay, so a multifidus activating exercise, well, originally the exercise that was called an alternating Superman, where you're face down and you're lifting opposite arm and leg, that is considered one of the better exercises for activating multifidus, because you're creating a slight extension and rotation moment, and that is what the multifidus does. Its action is to extend and to rotate. If you do that laying down, then of course that's relatively low load. If you do it in a 4-point position, that's perhaps more effective, because when you're in a 4-point position, the inner unit has to switch on a little bit more. And so it does facilitate the activation of the inner unit, so the deep intrinsic musculature of the abdominal wall and the lumbar spine. So I think that would be a good one. Without, the one I generally go to is something called a doll's hip maneuver, which is taught by Diane Lee. And if we do a practical, then that's what I'll show you. But essentially, that's the patient side lying, and they're kind of drawing the leg. So it's difficult to explain. But if you imagine you're side lying, one thigh on top of the other, you imagine that the top hip is dislocated, and you're using the muscles in the hip to actually suck the femur back in, or the ball back into the socket. And in doing that, what happens is you're creating a very subtle rotation through the spine, and the multifidus switches on. So it's a very, very subtle way to activate multifidus, but it's also easy to palpate in that side lying position. So that's a good one for multifidus isolation. In terms of duration, it's always 3 to 5 minutes for tonic fibers. Okay, so that's what that means, is it's the cumulative amount of time under tension. So it could be a 10-second hold, 5 seconds off, 10-second hold, 5 seconds off, and you do that, let's say 6 times. Well, that's 60 seconds of work. So if you do that for 3 sets of 6 repetitions, now you've done 3 minutes worth of work. So now you're just moving into that phase where you're really starting to condition the tonic system, or the type 1 fibers, which are the same thing. Type 1 and tonic, same thing. Okay, when you talked about increased prevalence of shoulder pain, tennis elbow, etc. with heart disease, was it established that this was proportionally greater in the left arm? I don't know. It wasn't in the paper. It wasn't in, they didn't say which arm it was. So initially I was looking at it thinking, oh, this could be central sensitization, because central sensitization can affect bilaterally. It depends on the degree of the sensitization. So it's not unilateral. Okay, it starts out unilateral or ipsilateral, I should say. So ipsilateral to the side where the pain is, but it can, if the drives are sufficient, it will become bilateral. Okay, so it could affect either arm theoretically if you're taking that kind of central sensitization model. But I think it's more likely that it's the allostatic load that's driving those conditions, as I discussed with regards to the Achilles tendinopathy. Okay, we're getting there. I think we've got maybe 2 or 3 more questions after this. So O'Sullivan strongly advocates away from core stability training in chronic low back pain. You showed fat infiltration and atrophy of the multifidus, but some research shows that there is an overactivation of the musculature. Is it the phasing muscles that I think that's phasic muscles that overactivate? Yes, it is. That's my understanding, at least. I mean, I can't be certain, but that's my understanding. I guess the main thing is to get patients to move and find what's meaningful for them in terms of movement, as they're more likely to adhere. Yes, absolutely. The most important thing is that they move, for sure. But if we know how to reactivate certain musculature, and the research seems to suggest that musculature isn't working, and we find that clinically, because there's lots of ways to assess for that clinically, then why would you not re-engage that musculature? I do think that when they find overactivity, I think it's probably because those phasic fibers, the more superficial fibers, are still trying to compensate. But I'd be surprised if those deep tonic fibers have re-engaged. So there's that. And then the next part of this was, I don't disagree that most control exercise might have a role to play in multifactorial approach to managing chronic low back pain, but with someone who is fear avoidant with overactivation of muscle, it might not be ideal to introduce motor control exercise at an initial stage. But interestingly enough, I understand what you're saying there, and of course you've got to do it on a case-by-case basis. So yeah, if someone's really concerned and you're using really bad language and saying, oh, you're very unstable here, and if you don't engage this muscle, your back's going to fall apart, that would be really bad for someone who's got fear avoidance and or anxiety based behaviors around their pain. But if you frame it optimally, then first of all, that's important, because you can see it, they can see it as a real beneficial step that they can take ownership and they can take control and they can improve it themselves without you needing to help. Okay, so that's one thing. So it's very empowering. But the other thing is that actually the research on motor control exercises shows that it's better than general exercise, in particular in the first 3 months. But by the time you get to a year, it's not discernible which is better, motor control exercise or general exercise. So actually what you're saying in terms of it being not so ideal to introduce early on, the research I've read says the other way around. It is ideal to introduce early on, because what you want is you want people to be feeling better. If they do general exercise, they don't feel better. They think, oh, that person doesn't know what they're talking about. I'll go and see this person. That person gives them motor control exercise and they feel better in the first 3 months. And so then they're much more likely to be compliant and to stay compliant with the program and the advice that you give them. So now there's research and research. That's the research I've read. If you've read something different, then great. But that's where my understanding is at the moment. So okay, next question is, do you know any reliable ways of testing for food intolerances? That's like the $1 million question. One of the things that Paul Chek is renowned for doing is sending in whenever a new test comes out, he sends in 2 blood draws from his arm under different names, taken at the same time, same day. And you know, so he might use his wife's name or a different address or something. And he's done this basically with all of the major food intolerance tests, and they always come back completely different. So so I would say there's not a reliable lab test that I know of, although they can be helpful because they do just make people that bit more aware. They tend to come up with foods that people tend to be intolerant to anyway. And so, but to answer your question, the most reliable way is a food exclusion diet, and then to reintroduce foods. So you can remove all foods that are highly allergenic. So, I mean, a paleo diet does that pretty much. So you could take a paleo type approach, and then you could reintroduce, for example, rice, see how you do on that, reintroduce wheat, reintroduce dairy, reintroduce, you know, things that aren't normally allowed on a paleo diet. And that would be a great way to test for food intolerance. But you've got to have people that are willing to do that and that are motivated to do that, you know, and also kind of body aware as well. So actually the next question was similar. It was, do you recommend food intolerance tests to help with IBS or central sensitization syndrome patients? And the answer to the question is not really. Food rotation is another thing that's very useful. So you can rotate. If you give someone a food rotation chart, they can eat certain foods on a Monday, certain foods on a Tuesday, Wednesday, Thursday, and then go back. And what you'll find is that quite often they'll notice they're more bloated on one day, or they're more fatigued on one day, or more achy on one day. And that's one way to start to gradually pick out which food they're not doing so well on. It's a bit more challenging, but it's possible. Okay, then I think, yeah, okay, so that was just clarifying the online practical session for now. Models, dogs, whatever, we can manage it in these times. That's true, that's true. Okay, well, yeah, we'll see what we can do. I think that was everyone. Everyone else. Oh, what are your views on FODMAP? Well, oh gosh, okay. Yeah, so FODMAP. So FODMAPs are, I can't even remember what they are, but they're things like fructans and oligosaccharides and monosaccharides and polysaccharides, and some people don't do so. They don't just do so well on them. And so my understanding is that FODMAPs can, in some people, particularly those with SIBO, which is small intestinal bacterial overgrowth, they can go down, essentially they get into the colon. The colon then doesn't ferment the foods as well as it should do. You end up with an overgrowth of colonic bacteria, and they go back up into the small intestine and create small intestinal bacterial overgrowth. That's my understanding of the pathophysiology of it. And it does seem to be a problem. I can't say that I've really delved too deep into it, because I think when you follow key lifestyle and nutritional principles, these things tend to clear up fairly effectively on their own. One interesting paper I saw recently is that they were looking at the biome of people that were paleo, people that were keto, people that were vegetarian, people that were, let's say, pescatarian or whatever. And essentially what you find is that each of those different groups has a very specific biome. And so, of course, it's not the biome that dictates what foods you eat, it's the foods that you eat that dictate the biome. So, this is kind of a little bit of a different way of thinking about it, because we're still thinking in that kind of old, soil and seed type scenario, that we've been infected with a certain bacteria, but really the bacteria are responding to what you eat. And so, if you want more of Lactobacillus, maybe you have to eat more vegetables. And if you want more of Acidophilus, maybe you need to eat more meat. And, so it's not really a case of supplementing with bacteria. It's about what you eat that determines the biome. It seems to be the way things are going now. So, with regards to FODMAPs, of course, if people are reacting to those foods, then absolutely, cut them out. And, of course, experiment again using a 4-day rotation or an exclusion diet, but reintroducing different foods, and bit by bit I think you'll find that the microbiome, as long as you can increase the diversity of what you're eating, the microbiome will sort itself out. Of course that's not always the case, but that's a good general rule to follow. So I think that covers everything. All the rest are, I think, lots of angina comments. But yes, thank you very much for listening. Thank you for staying if you stayed all this long time. And I'm sure the IO and Katie will be in touch just to let you know where you can get hold of it. Okay, so thanks and see you soon. Bye bye.